This week on the BackTable podcast.
Outside of training, you quickly realize that nobody's really looking over your shoulder, fact-checking you anymore, which is a little bit of a relief, but at the same time, it's also a little bit daunting because you're, in the exam room with the patient and you realize, wow, maybe I could go back and ask somebody for help, but I can't just depend on that from here on out. I have to be the one to make the decision and stick with it and know and trust that the decision I'm making is the right one. So that's a big adjustment, just going out into practice in general. I think in academics, one nice thing, I guess, is that you're going from your training, which has this big cognitive element, and if you're going into academics, there's still a really significant cognitive element. It's not just work and production, et cetera.
All right. Basil, good to see you, man.
Good to see you, Anish.
Hey, tell me about your trajectory and how you landed as an allergist where you are. Your training and kind of what took you into it and how you got here.
Sure. Well, allergy is one of those unusual subspecialties where you can come at it from multiple different places and enter into the same fellowship program. So you could be pediatrics trained, you could be internal medicine trained like I was, or you can be med-peds trained. And I was drawn to allergy during my internal medicine residency, which I chose internal medicine because I was like, this is keeping all my options open for subspecialty for a little bit longer so I can really decide where I want to go next. But essentially, that's what got me into allergy and immunology, being drawn to allergic disease, the immune system, having some of those conditions myself and being able to relate that to my own health and seeing what really worked for me over time and wanting to pass along some of that wisdom to the patient population. And then after my training ended, I decided to stick with academic medicine for 4 years. I was at Vanderbilt and then came back to Columbus where I'm from, and that's where I joined the private practice group that I'm with now. A couple other things happened along the way, yeah.
What are some of the highlights?
The process of actually choosing the subspecialty was not as easy as just, I woke up one morning and I realized, wow, this is where I really need to go. It was more of weighing different ideas that I had, thinking what suited me best along the way. And then, of course, leaving academics was a big challenge in and of itself, and leaving such a great institution with so many fantastic peers and the opportunities that being in academic medicine gave me, that wasn't easy either. But, there's pros and cons to academics and private practice. And I know we're going to talk about how to stay up to date on the advances in your specialty. And that's a little bit easier to do when you're in an academic institution than when you're out on your own in the community.
So what did prompt the change from academics to private practice? And I want to understand kind of what your day-to-day was like when you were training, once you got out of training, and then I guess really once you got into private practice. How did those change?
Yeah. Well, in training, of course, you're just trying to keep up with everything that you're expected to know. It's like whenever you're in training, whether it's residency or fellowship, anybody who's gone through medical training knows this. It's a combination of work and school. So you have to meet the demands of what your employer is asking of you on the work side, but you also have to meet the cognitive demands of passing your exams, passing your boards, studying for your in-training exam, being able to match a certain level of knowledge that your peer cohort has when you're going through rounds and working with them day to day. Outside of training, you quickly realize that nobody's really looking over your shoulder, fact-checking you anymore, which is a little bit of a relief, but at the same time, it's also a little bit daunting because you're, in the exam room with the patient and you realize, wow, maybe I could go back and ask somebody for help, but I can't just depend on that from here on out. I have to be the one to make the decision and stick with it and know and trust that the decision I'm making is the right one. So that's a big adjustment, just going out into practice in general. I think in academics, one nice thing, I guess, is that you're going from your training, which has this big cognitive element, and if you're going into academics, there's still a really significant cognitive element. It's not just work and production, et cetera. So going into academics, you're looking at, how can I get involved potentially in some teaching, some research, and how can I build that into my future in the same way that it was part of my past during my training. And private practice is a little bit of a different world than that because you're mostly expected to see patients, see a high volume of patients, and be the community-facing physician. But if you want to take on some additional responsibilities, there's room for that, not as much as in academics, but there is some room.
And so there's a lot less time for what you call the cognitive demands, once you're in private practice. When is that time, I guess?
It's not built into your schedule. It's more about individual choice, right? So it's not like in academia where you break down your schedule into this is my chunk of time that is going to be dedicated to non-clinical pursuits. And in private practice, it's more of like, okay, I have this set of time. If I want to take on non-clinical activities, whether it's teaching, hosting students, learners, residents, et cetera, or giving talks, that has to either be worked into my existing schedule or time has to be carved out of my schedule in order to commit to things like that.
How rapidly is the field of allergy changing?
Field's changing very quickly. That's a good question because people look at it from the outside and they say, oh, allergy. So it's, your own allergy and immunology is the full name of the specialty. And if it were up to me, I think I would take allergy out of the name and just call it clinical immunology. Allergy's in it because it's the most visible part of what we do because allergies are a part of the immune system. But, we deal with immunodeficiency. We deal with things like asthma, which is very much both an immune and respiratory disease and an allergic disease for the majority of patients who have it. And we deal with things like atopic dermatitis, which can be partly allergic or can be really not allergic at all. So not everything that falls into the specialty, the subspecialty of allergy and immunology is an allergy. It's an interesting question, though, about are there new allergies? The answer is yes, kind of. I mean, that part, that aspect of it changes very, very slowly. Obviously, there's a lot more cases of peanut allergy, for instance, just to cite a very well-known example today than there were 50 years ago. But I think a lot of what we think about as changes in allergy and immunology are changes in our management approach and new tools that are coming into being and new ways of looking at treating those cases of allergy than we used to have, for instance, even 5 or 10 years ago. So for instance, for food allergy, I mean, the long-term the paradigm that I was trained under, which was not that long ago, was you essentially tell the patient to avoid, you give them an EpiPen, you give them all the precautions in the world, and you may retest them periodically to see if their body has naturally outgrown the food allergen. There's maybe a little bit more nuance than that, but that's essentially the whole game, wait and see. But we now have newer therapies, newer biologic therapies for food allergy. We have new forms of immunotherapy now for food allergy. Immunotherapy for food allergy did not exist when I was in training, and I graduated in 2020 from fellowship. So it was kind of barely coming into being at that time. Now it's very much mainstream. Things like oral immunotherapy, bringing some kid in who has a lot of food allergies and putting them through a program that trains their body to be less sensitive to the foods that they're allergic to. That's a paradigm shift in how we approach food allergy. And that's the kind of thing I'm talking about that's always changing.
So you come out of training in 2020.
Right.
It's 2026 now. At the time, immunotherapy for food allergy wasn't a thing, basically, and now it's mainstream.
It was a thing in kind of some like pioneering, some ahead of the curve institutions were doing it to some degree, but it hadn't gone mainstream like it has now.
So when was the first time you heard about it?
When I was in training. I mean, we all saw that it was something that was on the horizon, but
okay,
we weren't sure whether that meant it was going to go mainstream in a year or two or 10 years or 15 years, who knows?
And then how did it make its way into, your mainstream?
Well, when I started to be approached by colleagues who were offering it, and they would say to me, some patients might be candidates for it. And, you do some CME, you learn about who's going to be an appropriate candidate for it, who's not, which kid would really benefit from it, or what kind of conversations you need to have with with the family of the child with the food allergy to solicit whether or not that's something that's appropriate for them. A lot went into laying the groundwork for making sure that the right people were being selected in order to do it. But when you have colleagues who trust, who say, yeah, I'm starting to do this and I'm starting to see great results, and they tell you, you may want to start bringing this up to your patients and sending me some of the ones who you think would benefit from it, then that was when it really became mainstream for me.
So did you read, let's just say, was there a JACI article? That's not really how it happened. It was really more colleagues were saying, hey, Basil, we're doing this and, you could use this.
I think it's all of the above. I mean, you have to read the papers and get a sense of what the evidence looks like yourself. And it was certainly more than just one paper that was published about oral immunotherapy, quite a few. We had a solid body of evidence before clinical trials were run, before the studies were published, and certainly before there was FDA approval, which then sparked a much wider expansion of that kind of a treatment in different allergist offices. But you can read about something 100 times and still not have a sense of how to make it a reality for your patient. I read about things that are happening in Europe sometimes, for instance, in these medical journals, and there's nobody in the US that's doing them. So I don't know if I could even offer it to my patient realistically. So it's a combination of reading the evidence, understanding the evidence, buying into it, and then the reality of what resources exist where you're practicing and where your colleagues are practicing enough to be able to say, okay, I'm going to actually start to move in this practice direction rather than the old way that I used to do things.
When there were the first approvals, did you hear about those instantly? You hear about those a couple weeks later? Like, how does this happen?
Whenever there's a brand new approval, I feel like I hear about it pretty instantly. Whenever there's a new biologic or other drug that's approved that changes how we look at and treat allergy, I feel like I find out pretty quickly. Oftentimes that happens through word of mouth or through press releases from national societies or social media, for instance. You jump on LinkedIn and you can immediately see that X company announces that their new drug for whatever condition I treat, atopic dermatitis or severe asthma, has just gotten approved, and you can read the full press release at the link that they shared. Things like that happen all the time.
Are you pretty active on LinkedIn as far as like scanning for updates, or Twitter or other social media?
Yeah, I would say LinkedIn is where a lot of updates are shared in the medical world, because medicine and pharma kind of intersects on LinkedIn in a way that maybe they do to some extent on other social media platforms. But I feel like that's where a lot of those conversations are happening right now.
In other specialties, I've heard for a while it was Twitter or X, especially in more the procedural specialties,
Yeah.
but not anymore, I think. It's kind of gotten a little trolled out.
Med Twitter had a moment, I would say, but it seems like it's past us. I haven't been sent nearly as many links from colleagues to, new announcements or interesting tweets in quite some time, or interesting X posts, if you want to call them that.
But do colleagues post regularly on LinkedIn, and that's like a good way to kind of keep abreast of what's happening?
Well, I think LinkedIn is one platform, and I'm sure there are and there will be others. People use Instagram also sort of for sharing medical content. Some creators do that, and some doctor colleagues of mine will occasionally send me things there too. And then Doximity, obviously. Doximity is something that we use because of the tools that are built into it to help us practice medicine. But occasionally, you'll have your Doximity feed and you'll see new announcements there, things being shared in kind of a little bit of an online medical discussion community. I know people use Facebook also. I currently don't.
It's different by specialty, but there's some specialties that have very active groups on Facebook, which are tremendous. Once you have a group like that, that's tremendous.
I would say mine is more local, though. And by that, I mean like group chats. Once you have an interesting group chat of doctors that you have become colleagues with or even just friends with over the years, whether it's in your specialty or whether it's in a varied specialties. Like I'm in one group chat it's been active since 2021, and we're in 15, 16 different specialties. It's not all medical, obviously. You know what I mean? It's one of those things where it's like, sometimes it is. We'll talk about, oh, here's a crazy case I saw today. Like, check this out. Sometimes it's more like, here's something that I'm working on right now. Want to get your guys' thoughts on that, or here's a change that's happening within my institution. So we'll talk about those types of institutional challenges that happen in different practice settings. That comes up all the time also. And it's interesting because you see things like what's affecting a general surgeon or a trauma surgeon at their hospital or their institution is way different than what's affecting somebody like me in my specialty. And then sometimes it's just sharing memes, talking about, personal things, sharing life updates, things like that. So it's just like any other group chat of friends, but it is a way to cross collaborate and exchange a lot of ideas and really pick up on and get the pulse of what's happening in different aspects of medicine than what you're normally seeing in your day to day.
When do you scroll LinkedIn? Is that, like woke up, I haven't like gone downstairs to grab some coffee yet. So like I'll see what's new on LinkedIn, or is that like between rounds, or, I just got home. When do you find the time to actually even scroll LinkedIn or check your various email updates or however they're coming in?
Yeah. I think it's something like that where it's just a click of the button on your phone. I try not to just sit there and scroll in between patients or in between commitments at work. I mean, if there's like something I have to respond to right then and there, I might. But in terms
Yeah.
of like posting or in terms of commenting or seeing what other people are posting, that's usually built into sometimes actually my gym time, in between workout or in between sets or things like that. That might be something that I do then, or like during my admin time. So if I have like a couple hours, I have a half day off during the week, I'll do it during that. Or if I have a couple hours over a lunch break, my first patient of the afternoon hasn't showed up yet, that's a good time to do that as well.
Is it more something you've like dedicated the time to doing, meaning like, okay, I know I have to do this, or it's like, oh, I actually want to do this. Like I want to go see what's happening on LinkedIn and kind of scroll through.
At this point, it's more of I want to do this rather
Yeah.
than I have to do this. Yeah, because I mean, there are people that go in that have a strategy of like, oh, I'm gonna, post every day and try and reach this social media milestone. But if it's more just how do I use this to improve the career that I already have, then it becomes after a while something where you're just like, okay, I'm learning a lot from this tool, so I'm going to keep using the tool periodically to, reinforce and to help me sharpen my day-to-day work and what I do,
Yeah.
and to keep people informed about, other things that I'm working on right now and kind of form communities around that too.
Yeah. Do you post? I mean, I guess you're an active poster as well, not just passive.
I think I think, and that's why when you were talking about the Twitter and Med Twitter, when it had that collective movement, I think it was because there was so much engagement in terms of people posting and people reacting to each other's content and not just passively observing. So, I mean, I really just saw the tail end of that, but you don't get nearly as much out of any social media platform or any online platform that you're using if you're just consuming and not contributing.
And I mean, all of this that we're talking about, I mean, I guess BackTable is kind of a part of that,
Hmm.
but it contributes to, for lack of a better word, a democratization of information sharing, meaning like more physicians can share more with their peers than previously.
Yeah.
Previously it's like you had a journal article, maybe a conference talk, occasional webinar, the equivalent of an angio club, whatever
Right.
that is in every specialty. Like the opportunities for sharing really decrease after after journal and conference. It like drops off. But now that's not the case. There are way more. What's your take on that? I mean, quality of information can get diluted on the one hand, or there's like
Hmm.
so much more of it. You can get it. It could be way better. I guess. What's your take on? Has that been a good thing or a bad thing or a mixed bag?
I would say it's a mixed bag. The bad aspects of it, if you want to call it that, I'm not even sure it's totally bad, but it places more of the burden on the consumer of information to be able to discern this is a good resource or this is not a good resource, or to pick and choose which kinds of conversations they're really interested in listening to. Because, yeah, you're right. I mean, Backtable is part of that ecosystem now. You guys have really found a way to build an audience and bring voices onto your platform from an educational standpoint, and really voices from practicing physicians, which is not quite the same as bringing people together for a journal club or bringing people together for a national conference where it's top researchers presenting research. I think nowadays you'll see every single journal of every publication pretty much now has its own podcast. A lot of institutions have their own podcasts. Medical schools have their own podcasts. A lot of also national organizations, academies, et cetera, have their own podcasts where they give voice to a wide range of people within the organization and within their specialty group or whatever it is, not just the really big time researchers and other physicians in the field or the ones that are tenured professors, for instance.
Yeah.
So what that does is rather than everybody listening to the same 4 or 5 or whatever shows and hearing the same things and having the same conversations about them and each show getting 50 or 100,000 views or listens or whatever you want to call it, it breaks it down into much smaller segments of the total population. And because of that, you need to really be mindful of, again, what you're consuming, who it's being produced for, who you're hearing from when you're listening to it, and maybe find ways also to, because it's smaller, find ways also to engage with it in a way that allows your voice to be part of that conversation.
Yeah, and I guess everybody gets better at just consuming information from a variety of sources. Like you said, there's nuances to each new source of information. You can't just have one trusted source because it doesn't even work that way anymore.
Yeah.
And each audience is a little bit unique. So you got voices for a specific audience.
Yeah, definitely.
Let me back up and ask you a question that's been on my mind, actually, that's a little bit off topic. Why are allergy and ENT practices combined?
That hasn't always been the case.
Yeah.
They are becoming combined, I would say, more so than they are combined. I think if you go back decades, you'll find allergy practices and ENT practices pretty much separated from one another. I think consolidation, a lot of incentives economically, and I'm not an expert on medical economics or the business of medicine. I don't claim to be. Having said that, I've studied enough to know that a lot of incentives of just how the healthcare system works over the years have pushed people towards consolidation. So you see bigger practices now rather than not nearly as many small solo practices and more integrated practices. And I think where there are opportunities for synergy between, for instance, a group in allergy and a group that's ENT, where they're going to be referring to each other quite a bit and they're going to share a lot of patients, and there's overlap in terms of some of the conditions that they treat, and they can help one another out. I think bringing those two groups together under one roof and one organizational structure where they can offset some of the costs and contribute jointly to the success of the group. Maybe it doesn't always make sense everywhere, but a lot of cities and a lot of organizations are finding that, yeah, that is something that makes sense. And so that's why that pattern's being played out.
So put simply, it's an overlap of some conditions and the treatments for them. Not all conditions on ENT, allergy. There's a variety of things that are completely separate, have no relation, but in the Venn diagram, there's an overlap. And that's what has brought the groups together.
I think that's part of it. I think another part of it is probably also patient care, to be totally fair. I mean, if you're sending 5 patients to ENT a day, or they're sending 4 or 5 patients to allergy every single day, the success rate of ensuring that the referral is going to get to where it needs to go is way higher if you're under the same roof in the same organization than if you are in 2 different organizations. So if I have to refer to you and you're an ENT colleague, and I'm in a solo practice in a strip mall, and you're in a solo practice in, an outpost somewhere, then the odds that this is going to get lost in translation if I'm sending you the referral to where you are, way higher than if you and I are right next door to each other, or I can just walk over and say, hey, I've got this referral for you. Referrals are something I'm also working on right now, and working with a group to try and improve and speed up that process of and optimize, because that's an area where we found some challenges in going and referring to other practices. But within my group, I've noticed how much easier it is to make sure that the patient gets the quality of ENT care, for instance, versus making sure that my patient gets the quality of a different specialty of care that's outside of our group.
Yeah. Okay. Much better patient care. Basil, that's really all I had and wanted to get into. I guess anything else on this topic that I didn't ask about?
I would just reinforce that there's so many ways to get information now. So, even if the big question is how are you staying up to date with your field, a BackTable is a fantastic resource. I mean, so many people I've talked to now have subscribed to the podcast and just week after week gotten great updates from the show and the things that they've listened to and heard. And you guys bring on guests that can talk about a wide range of things within, ENT and allergy, my world, and I'm sure the other podcasts as well. But there are many, many, many ways. So if podcasts aren't your thing, there are other ways also to stay abreast of the information. And you don't have to just wait for the next journal to come in the mail and do it a really old school way. There's so many ways to do it now. We didn't even talk about AI, but there's things like medical GPT, open evidence, things like that, that give you access to so many resources where you could just, if you're on the fly, you're a busy practicing clinician, you're in between patients, something's eating you about the last case that you saw, and you want to quickly get a sense of what the evidence tells you about that condition that you think you're dealing with, just punch it into one of those medical tools that you are subscribed to, and you can learn so much just from that and, have access to the primary resources to be able to read about that evidence. So it's a great time to be somebody who's looking for new ways of staying up to date with the medical information. It's really not that hard, I think, compared to before.
Yeah, it's way easier now. You're right. We didn't get into AI and we should have. So let's just do that for a minute because I'm curious.
Let's do that.
Let's say open evidence for the moment. Do you see it as more for you decision support or learning? And like, where's the line between those two? Meaning like, I am doing this case in 20 minutes or like, I just did this case, like you said, when I'm like, understand something versus like, okay, I'm just generally getting information.
I think for the most part, though, it is decision support or it's information, it's targeted information seeking, right? You're not just going to sit there and have a full length conversation with AI about, or maybe some people do this. I don't know. I've never done this before. I've never gone to Open Evidence or ChatGPT Health or Doximity or anything like that and started typing in, bring me up to date on everything that's happened in allergy and immunology in the last 2 months. Maybe you can do that, but yeah. I don't think that that's a good use of resources. I think the right use of resources is, let's say I see there are conditions that are pretty rare that I see in allergy and immunology, so hypereosinophilic syndrome is one of them. And that might not even be something you guys are tuned into, but it's a rare condition and I get cases of it every once in a while. And if I really want to run it through and say, okay, what are the guidelines for management of cases of hypereosinophilic syndrome where the patient has failed this, and this, and they've been through multiple steroid courses and it's still not getting better, et cetera. That's where AI can really be helpful in summarizing the evidence. And like I said before, in giving you the references for further reading, if that's something that you're interested in, and really going back to, if you don't trust the AI's output, you have the reference right there. You can look it right up. You can read the paper yourself and see whether you came to the same conclusion. But as just a quick way of accessing that information, I think the AI can be a really good tool.
And are you finding that your patients are coming in more informed? Like they're talking to ChatGPT before they come and see you? Has that made its way into your practice or into your patient experience?
It has. Yeah. I mean, not every day, but, sometimes patients will come in and say, hey, I was asking ChatGPT about these symptoms here, and this is what it told me, that could be part of the differential, or this is a maybe. Fortunately, I don't think people are going to the level of, I asked ChatGPT and this is what it told me, so this is what I have to have. At least that hasn't been my experience yet.
Yeah.
But they'll bring some insights from ChatGPT. And it's what it is. We have to be just ready for that conversation. I don't even know that we can discourage the use of tools like that. If you only have 15 minutes with your patient and the patient has a supercomputer in their pocket, then how much can we really be upset with our patients that they're going to use that tool to get something out of it? I hope that they take into consideration the expertise of their doctor, and they should, but that doesn't mean that the AI and things like that aren't here to stay. They are.
Yeah. Well, I'm definitely one of those patients who has long conversations with AI before I go see my doc. As a layperson, I'm like, hey, doc, this is kind of what I want. But like you said, there's room for, I'm seeing the doctor for a reason. I didn't just tell him what I wanted. I'm like, hey, this is what I think I want, but let's talk through this.
As long as you remember that you're seeing your doctor for a reason and you're not just there to order off of a menu,
Right.
You're not just there to be like, here, ChatGPT told me I should get a double bacon cheeseburger.
I wish it would tell me that.
You haven't entered the right prompts, clearly.
Yeah, exactly. Okay. Let me go reverse that. Basil, hey, thanks for taking the time and sharing how you do this. I appreciate it. Our audience appreciates it. And thanks for all the great work you do here on BackTable as well.
Thank you, Anish. Thanks for all your hard work, too.
All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a BackTable hoodie in your future. If you have questions or comments, DM us. We're @_BackTableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.